If it's symptomatic grade 2, we're going to have to stop. I tell the patients up front that we need to do this because I got to find this asymptomatic. And, if they do have any symptoms at all, of course, we need to know. But, I need to know if it's in the context of, a URI, for example, or allergies are kicking up or whatever. Because I tell them, let them know that if it's symptomatic grade 2, we're going to have to stop. And so that they really, we really are on the same page about getting these scans done. If there's anything there, I stop and I give a course of steroids, about a 4 or 5 week course of steroids, and then repeat the scans. It takes quite a while for it to go away completely. So, but I would resume. I resume at a lower dose. I go down a dose. I don't want it to happen again. Basically, and I know that the data show even with maintaining that dose, it's still only about a third of patients that have a recurrence of it. But still, I'm going down because I think this drug has some therapeutic window on it there. But then, it's very tricky if they're a little bit symptomatic. Because there's all kinds of reasons. We have lots of allergies in Texas, for example, a lot. And then it's flu season, et cetera. So it's hard. And but we have a little bit of data on rechallenge with grade 2. But most of the time, if I think it's ILD, I will not rechallenge if it's grade 2. If it's real. But if I think it may not be, reflux is another big thing we see. Yeah. So I have patients. If they have a history of taking them, I make sure they're taking them because that's going to confound things as well. But I really think that the only time I've seen trouble with the agent was very, very early on when it first came into our practice. And we just have to really have a heightened awareness. I think the hardest thing is for patients with a lot of other lung disease, and they will have a pleural effusion and obscure some of their lungs. Those are the most difficult patients. But when in doubt, err on the side of holding and then treating with the steroids. I think that's really the key.
Fantastic. One last thing I want to touch base on with Dr. Mawi, the nausea. All right. So I feel in my practice since I start implementing olanzapine, low dose olanzapine, 2.5 milligrams, sometimes even half a tablet. I tell them take 1.25. It changed completely that perception of the drug. What has been your experience?
I agree with that. So we medicate for it as a highly emetogenic, but I cannot take credit for it, but a clinical pharmacist recommended that to me. And so I was like, well, let's try. And it works. I agree with you.
Yeah.
It works well. And I think to the extent that if the patient do well for a number of doses, we start dropping some of the other meds, particularly if you're starting to be worried about their blood sugars, you can drop those steroids. And if you worry about, some of the side effects like constipation with anti-nausea medicines, you can kind of lower it a little bit. But I do agree that olanzapine has really transformed the way we see nausea. And I actually use that trick that I learned from our clinical pharmacists and other regimens as well.
Yeah, fantastic. Any last remarks do you guys have?
Just I agree with what Mo said too about how fatigue can be cumulative.
Yeah.
And dose reduction really does help. And then I've had patients go on with their dose reduction and do well for a very long period of time. Then they're tired again, so you dose reduce again. You know what I mean? So dose reduction really does work for that.